Welcome to Lesson 3, where we will focus on enuresis. The scripture guiding this lesson is from 1 Thessalonians chapter 5, verse 11. Therefore, encourage one another and build each other up, just as in fact you are doing. Enuresis is the medical term for bedwetting. It's a very common disorder in childhood, and it occurs worldwide at around the same rate. 10% of all 7-year-olds still wet the bed at night, and 2 to 3% during the day. Enuresis can be associated with emotional distress, both in the parents as well as the child, and it is reversible once the child stops bedwetting. Achieving continence is therefore the main goal of treatment because it helps with improvement in self-esteem as well as self-confidence, as well as strain in the parent-child dynamic. But about 20 to 40% of all children with enuresis have additional comorbid psychological disorders, such as attention deficit disorder, oppositional defiant disorder, as well as depression. And these comorbid disorders require additional assessment and treatment. There is treatment for enuresis that is based on both pharmacological interventions as well as behavioral interventions. And so we'll talk about some of those. Enuresis is defined as involuntary or even intentional incontinence of urine in children aged 5 or older, after organic causes have been ruled out. Bedwetting that occurs during the nighttime is termed nocturnal enuresis, but occasionally it does occur even during the daytime. It must be occurring for at least 3 months in order to be considered a disorder. And regarding classification of enuresis, primary enuresis means that the child has been dry for less than 6 months or not at all. And secondary enuresis means that a relapse has occurred after a dry period of at least 6 months. The dry period can occur at any age. This distinction is important because children with secondary enuresis often have experienced stressful life events such as separation of parents, birth of siblings, or other situational stressors that have triggered this resurgence of symptoms. These issues are important to consider in assessment as well as treatment. But otherwise, the treatment of primary and secondary enuresis are very similar. The classification of daytime urinary incontinence is more complex. Sometimes there can be functional or organic urinary incontinence, but that is usually rare and may be associated with structural, neurogenic, or other medical causes. So it's important to rule those out. The 3 main syndromes of functional urinary incontinence are urge incontinence, voiding postponement, and dysfunctional voiding. Additional rare syndromes can occur, including stress incontinence, giggle incontinence, detrusor underactivity, and urge incontinence or overactive bladder can also be characterized by symptoms such as micturition frequency and small voided volumes. Dysfunctional voiding can be a disorder of the emptying phase, where instead of relaxing the sphincter muscle, it's contracted paradoxically. So you can see that stress incontinence is rare in children as opposed to adults, but wetting during coughing, sneezing, or other um, intra-abdominal pressure experiences can happen. So it's important to identify what the associated symptoms are when a child presents with incontinence. Nocturnal enuresis is 2 to 3 more times common than daytime enuresis, and it's much more common in males versus females. Daytime urinary incontinence is 1.5 times more common in girls, though, than in boys. Occasionally, one of the most frequent issues with monosymptomatic enuresis is the experience of deep sleep and just not waking up to go to the bathroom at night, or difficult arousal. Although increased urine volume at night or polyuria can occur as well with large wetted volume. And here, looking at voiding patterns during the daytime would be important. The typical presentation is a child who has difficulty waking up and wets the bed with large amounts of urine. Children with non-monosymptomatic enuresis have the same symptoms, but in addition, have signs that are similar to those as children with daytime urinary incontinence. That means that they may go to the toilet infrequently or postpone voiding and may have signs of urgency or frequency. Urinary tract infections, constipation, and encopresis are also frequent comorbidities. Secondary enuresis is the occurrence of bedwetting or incontinence after successful achievement of potty training and is often triggered by stressful life events such as separation or divorce of parents, the birth of a sibling, um, and as well can occur with children that have comorbid behavioral or emotional disorders. The treatment, however, and presentation is often very similar to those with primary enuresis. Children with urge incontinence frequently have a history of frequent urination throughout the day, sometimes more than 7 times a day, and short intervals in between. And they often have a lot of urge symptoms and incontinence with small volume, and behavioral approaches that include holding maneuvers or scheduling um, voiding patterns throughout the day with increasing time frames, such as waiting 2 hours before going to the bathroom and then 3 hours, as well as pelvic floor exercises can be helpful in a treatment plan. Urinary tract infections are commonly associated and so also need to be evaluated. Signs of voiding postponement can include a frequency of urination that is less than 5 times a day, and as well postponement of urination during certain situations, such as during school, play, reading, watching TV, And it can be associated with anxiety disorders or uh, other symptoms. But increasing postponement can help, and holding maneuvers can be instituted to prevent this urge incontinence. Genetic and neurobiological factors can be associated as well as environmental influences. So, genetic evaluation can be helpful as well as consideration of the environmental factors. Oftentimes, you will see that there is a strong family history of enuresis, and it is often a genetically determined maturational disorder of the central nervous system. 70 to 80% of all children with enuresis have affected relatives. So, the main mechanisms responsible for the development of enuresis include an increased urine volume or alteration in circadian rhythm, as well as changes in the antidiuretic hormone. Impaired arousal is another important factor. 9% of children with enuresis can be woken up. Finally, children that have an inhibition of pontine micturition center of the brainstem can be the problem. When the bladder is full during sleep, they're not able to sufficiently suppress emptying of the bladder. The identification of enuresis as a physiological condition or a genetic problem can be reassuring for children and families. There is, however, a high comorbidity of other psychological disorders, such as ADHD, separation anxiety, social anxiety, phobias, generalized anxiety, depression, conduct disorders, oppositional defiant disorder. And it is important to make sure that the individual receives treatment for all of the issues and symptoms and concerns. A workup for enuresis requires careful consideration, identification, evaluation of any physiological or organic causes. So, assessment and careful diagnosis are the basis for successful treatment. Most of the diagnostic process is based on good clinical practice and assessment of history, and each child needs a physical exam. And oftentimes, laboratory evaluation that includes things such as urinalysis, a urine culture and sensitivity, as well additional assessments including ultrasound or EMG or other urodynamic um, evaluations, including cystoscopy, may be needed. The use of a 48-hour frequency volume chart can be very helpful in understanding patterns of urination. Parents are asked to observe, record, and measure when and how much their child voids and drinks over the 48-hour period. Additional things such as incontinence, holding maneuvers can also be evaluated. Parents are usually given a simple plastic measuring cup. that they use to complete this process. The chart gives essential information that can help with diagnosis. And this flowchart just outlines the routine assessment that requires evaluation of both emotional and behavioral symptoms. Let's talk about treatment for enuresis. So, overall, there are either two approaches: non pharmacological or behavioral interventions, or medication, though the medication options are pretty limited. It's recommended not to treat before the age of 5, as there can be some developmental immaturity issues going on, and treatment should very much be symptom oriented. Psychotherapy is not effective, and the comorbidities do need to be treated, but it's so important to treat them separately so that the child doesn't relate the enuresis to another issue, such as the ADHD or depression. And if the child also has encopresis and constipation issues, they should be treated first. It's also imperative to treat daytime enuresis first because that is very disruptive and impairing. And it's important to identify whether it is primary or secondary enuresis in your history. However, they are both treated in the same way. So, there are a couple of behavioral interventions that we'll talk about. And otherwise, supportive counseling is helpful, as well as star charts to really motivate the child to focus on anything they can do to improve this problem as well. So, star charts are a great way to incentivize and have a contingency management to support the behavioral change in this area. It's important to alleviate guilt. There's a stigma with bedwetting. If there are siblings, oftentimes there can be a lot of teasing, and so that's really important. Now, some of the behavioral changes that the child can make do include things such as fluid intake, encouraging higher levels of fluid intake during the daytime if the problem is a nocturnal enuresis, and then toileting programs, toileting regimens, toileting um, patterns that we'll talk about as a mechanism for assisting in bladder capacity, as well as encouraging voiding before bedtime as well. Um, Now, things that are ineffective do include things like punishment and fluid restrictions. So, we certainly don't like to see children not getting enough fluid intake because a parent is limiting fluid intake before bedtime, but not encouraging adequate fluid intake throughout the day. And this can be very dangerous. And again, parents coming in and waking a child and bringing them half asleep into the bathroom to urinate before they go to bed, as a way that they're seeing it as, well, this is going to prevent me from having to clean, wet sheets in the morning. And but that is not effective. And then there are really very limited medication options as far as effective approaches. So certainly, um, ineffective medication options would certainly not be helpful. If the medication isn't working, we don't certainly want to continue it. And so this graph is showing some of the most effective approaches for treatment. And we see here the first two: the alarm therapy, which we'll talk about, otherwise known as a bell and pad or wet stop. That looks to be the most effective, both at the end of treatment as well as carrying over into follow-up. But combining it with behavior therapy is obviously the most effective, both at the end of treatment as well as in follow-up. And so here is a diagram showing the alarm approach, otherwise known as the bell and pad system, where there is a monitor, a device that senses wetness and rings a bell or an alarm that wakes the child up if they begin to urinate. The alarm wakes them up so that they can then go to the bathroom and complete the voiding. The alarm usually, when it jolts them awake, the sphincter closes and the urination stops, so that usually it can result in only a very small amount of urine. And so there are a number of different companies that make this product. And again, it's really good to incentivize the use of the bell and pad with a star chart system. And so this can be one approach. Now, of course, it does have some considerations, but it is pretty effective, especially when combined with some behavior therapy. Now, you must admit the alarm system or the bell and pad system can sound a little bit challenging. So some families may not decide that that's for them and prefer to try a pharmacological intervention first. Certainly, we know in general, many individuals do prefer pharmacological interventions over behavioral interventions anyway. Although we also know that the combination of the two are usually more effective. So if it is a family system that's very chaotic and can't have consistency with setting up the bell and pad system before going to bed, or the child's really not motivated, then perhaps that bell and pad system is not the first choice. So the medication approaches that are available, there are two, really the only two that have ever been approved for this treatment. And one is desmopressin, which is a nasal inhaler. And the other is a use of a tricyclic antidepressant, imipramine. Now, imipramine does cause some urinary retention, and it does have some anticholinergic effects that are drying, so that's how it works. It's really not something that I've seen a lot of positive response to. So I would suggest if medication is the approach the family is looking for, then the desmopressin is the best option there. So desmopressin, or DDAVP, is actually available in a tablet form as well as the nasal inhaler, and it is a synthetic antidiuretic hormone and is highly effective. Some suggest in 70% of the cases. And um, some studies have shown a relapse after discontinuation, so treating for a long enough period of time is very important. It is important to monitor intermittently for hyponatremia. Let's consider the following case study. John is a 7-year-old male with a report of bedwetting 3 to 4 nights a week. He was potty trained by the age of 3.5, but he always had nighttime accidents. Mom is very frustrated with the morning routines of laundry, and he was invited to a sleepover and does not want to wear pull-ups anymore. What is your diagnosis and treatment plan? Well, your diagnosis may be primary enuresis. since he always had nighttime accidents and was never fully potty trained. Now, treatment plan should include consideration for use of the bell pad. It does seem that mom and child might be very motivated to adhere to such a regimen. And a reinforcement with a behavioral plan, including a star chart or a contingency management program, where he could receive a star for his participation with the bell and pad each night, as well as a star for avoiding patterns throughout the day, being sure to empty his bladder as well before bedtime. This child may also be a candidate for the DDAVP. And here is a very heartwarming testimony from a former patient of an individual that had nocturnal enuresis for many, many years. In the course of 40 years, I have consulted a wide range of experts in the hope of finding a solution to my nocturnal enuresis. Most of the family doctors advise stopping drinking and methods of awakening in the night. Urologists performed various technical studies that showed no abnormalities. Alarm systems usually gave relief for a short period. Consultations with the naturopath and homeopath yielded no benefits, and consequent disappointment resulted in new mental strain. I consulted a psychologist who, although unable to find anything abnormal in my personality, advised Pavlov's method of adaptation. Immediately after waking with a wet bed, I was to take a cold shower as punishment for the bad behavior. A urologist prescribed imipramine, despite its severe side effects, including excessive sweating, dizziness, and a dry mouth. The psychiatrist used sandpit therapy to trace traumatic experiences in childhood. Recognition and acceptance of precipitating experiences might, it was hoped, remove the cause of my enuresis. 2 years of weekly sessions of 45 minutes had a major influence in my personality. Sandpit therapy, with its focus on the ego, changed me from a sociable to a self-centered individual. Again, the bedwetting was unaffected. Finally, after nearly 4 decades and many years of disappointing experiences, I consulted Professor Jagnat, who suggested desmopressin, DDAVP, an analog of an antidiuretic hormone. Used as a nasal spray once a night, this brought immediate relief. Discontinuation of the spray immediately results in bedwetting. So far, there have been no side effects. Over the years, the intrinsic difficulties of nocturnal enuresis have been compounded by the effects of these unsuccessful treatments. So, in conclusion, there is help and there is hope for enuresis. And enuresis can be very upsetting to both the child and the family. So consider use of the bell and pad, behavioral contingency plans, as well as the use of DDAVP.